The sign of a great leader is wrapping up his session a few minutes early. Thank you, Terry, for keeping us on time. That was terrific, and congratulations. We're going to go ahead and move on to the John Conley Lecture. If I could get my slides for that, please. It's my pleasure to introduce the John Conley Lecture this year, and that's Antonio Tito Fojo, who is joining us this morning. We heard so eloquently from Pat Glane yesterday some descriptions around John Conley, and he certainly is one of the legends in head and neck surgery. He was a graduate at the University of Pittsburgh and ultimately became clinical professor of otolaryngology at the College of Physicians and Surgeons at Columbia University here in New York. An amazing leader of our field, had over 300 publications, and was the founding member and the first president of one of our parent societies, the American Society of Head and Neck Surgery, as Terry alluded to. And as is the tradition, the Conley Lecture is often from a leading expert outside our specific field, bringing in other elements of either cancer care or treatment of our patients. And it's a pleasure this year to welcome Dr. Antonio Fojo, who is joining us from the National Cancer Institute. Dr. Fojo is originally born in Havana, Cuba, and moved to the United States in 1960 with his family, completed both his MD and his PhD at the University of Miami with his PhD in biochemistry. He then spent some time in the Midwest, completed his internal medicine residency at Barnes-Jewish Hospital at Washington University in St. Louis, and then spent 3 years as a clinical associate at the NCI before joining the intramural program as a senior investigator. He currently is the head of the experimental therapeutics section at the genitourinary malignancies branch at the Center for Cancer Research at the National Cancer Institute. His research really focused on the development of drug resistance in cancer, and in particular of multiple drug resistance, and working through both basic science and translational research, looking at the mechanisms and acquisition of resistance of drugs and how that affects the patients. His lab and his clinical research is focused very extensively actually on endocrine cancers and diseases such as adrenocortical cancer as well as pheochromocytoma. He has over 230 published articles, edited a textbook on the role of microtubules in cell biology, neurobiology, and oncology. He's currently the senior editor of Cancer Research and associate editor of 5 other journals. He's received multiple accommodations, medals from the Public Health Service as you serve in the National Cancer Institute, and it's a tremendous honor to have him here today to speak with us. And he's going to talk about the cost of cancer care by the numbers. Dr. Fojo.
Let me just be sure I where the advance button is. Back. Okay, there we go. Okay. Thank you very much. Thank you for the invitation. I'm very honored to be here, and also enjoyed the last hour enormously, and gave me some insight into organization that I didn't have before I started. So I'm very honored to give this lecture, and as you might imagine, when you're giving a lecture in honor of someone, you want to know what that someone would think about this lecture, and it's undoubtedly in my mind now that Dr. Conley would be interested in this topic. But I was looking through his bio in the AHNS site, and I noticed that he originally interned in Pittsburgh, and then he was asked by the nuns there, so the nuns suggested that he go and he get a degree in cardiology and come back and be their cardiologist. And so off he went to do it, and you think anybody who would do this can't be all bad. But then as I was reflecting on this, I remembered being taught by nuns myself, and when a nun tells you to do something, you do it. So, but the other thing that was interesting was that shortly after he began that, he had an episode of paroxysmal atrial tachycardia, which I guess nobody thought at that time was something you should take lightly, and today we consider it a more benign condition. And he was told that cardiology was too stressful, and that he should go into an easier, less stressful field with better working hours like ENT. So I'll leave that all to you, but I guess maybe things have changed an awful lot since then. So, but things have changed an awful lot because not long after Dr. Conley was the first president of the organization, there was a lot of drugs beginning to be developed in cancer. And you can see here on the right-hand side their prices when they were approved. And it's remarkable how little we paid for drugs then. At the bottom, you see interferon alpha. I remember as an intern, as a fellow, when interferon was approved, and we thought everything had gone the dogs. Look at that, $742 for this drug, and we didn't know what was yet to come. So while the title is what was mentioned, what I intend to do today is to talk about unintended consequences of expensive cancer therapeutics, and it's things that I think affect all of us, and it's the pursuit of marginal indications, and I'll come to that, and a Me Too mentality that is stifling innovation and creativity. And so, at the outset, let me make it clear that I fully understand we find ourselves discussing the problem of drug prices because everyone involved is striving to do their best in the care of cancer patients. However, the spiraling cost of cancer therapies has no villain, and I sometimes get accused of making drug companies appear to be the villains, and that's not my intent. But many of us are responsible. Academicians, the industry, professional societies, scientific journals, practicing oncology, regulators, and patient advocacy groups. We all contribute to the problem, and we all can help to solve it. For me, an interest in this began at ASCO in 2008. I was sitting in the audience at the plenary session, and they presented this, a drug that you all know from another context, cetuximab. This was in non-small cell lung cancer. And this was supposed to be a great advance, and I couldn't believe they had 20,000 of us there at ASCO listening to this, a 1.2-month survival advantage. And by the time the plenary session was over, I had already written the manuscript in my head, but I knew I needed help. I knew that this was, at some level, an ethical issue, and so I went home and I got Christine Grady, an ethicist extraordinaire, to work on this with me. And we published this article, and I thought I was done. And when it came out, I was real happy with it. And then my wife, who's also a medical oncologist, said, "What are you going to do next?" I said, "What do you mean?" She says, "Well, if you just do this and don't do anything, it'll look like a flash in the pan, and people won't take you seriously." So I thought I better get more interested in this, or my wife would think I was a flash in the pan. But today the point I will seek to drive home is what I see has really emerged as the real problem of expensive cancer therapies. And that is that they're stifling progress by encouraging enormous expenditures of time, money, and resources on marginal indications. And they're stifling innovation and creativity by promoting a Me Too mentality. So we're going to do this. We're going to do this quick. Hang on, and we'll just go by the numbers. So let me at the outset say 0, which is the number of conflicts that I have. Now, 552,200. That's the American Cancer Society estimate of cancer deaths in the United States in 2001. And the ACS estimates, as you know, are usually pretty much on mark. That was the year imatinib was introduced for the treatment of chronic lymphocytic leukemia. And in essence, the targeted therapy area began. 585,720. That's the American Cancer Society estimate of cancer deaths in 2004. So 12 years after we started the targeted therapy era, 33,520 more patients will die than they did in 2001. Now, more are going to die in 2014, in part because the population is aging, as I am compared to the picture you saw at the beginning. But more will also die in 2014 because we have failed to make the progress we would most like to do, and that is to deliver cures for our patients. 71. That's the number of approved drugs by the FDA between 2002 and 2014 for the therapy of solid tumors. And I don't expect you to read this table here. It's actually in the online edition of the talk that I'm giving you today. 2.5. That's the median number of months of progression-free survival. In other words, the median number of months of delayed in progression for the 71 drugs approved by the FDA between 2002 and 2014. 2.1. That's the median number of months of overall survival gained by these 71 drugs that were approved by the FDA between 2002 and 2014. And unfortunately, many of these are for the same indications. So it's not like we've built 2.1 months on top of another one and on top of another one. The progress that we're making is clearly not what we would like it to be. Now, not surprisingly, another number is important, 582. Okay, thank you. 582. And that is the median number of patients that were enrolled in trials for the 71 drugs that were approved by the FDA between 2002 and 2014. Large numbers were enrolled because marginal outcomes were anticipated. And so this is a problem that we have and one that I'll be addressing. So 2.5, 2.1, 582 patients, we can and we should do better. And we must discourage the pursuit of marginal outcomes. Otherwise, we won't succeed. So the American Society of Clinical Oncology thought that this is an important issue. And they recently convened the committee, and I was aware of the deliberations that were ongoing. And they said, what should be meaningful goals that we should achieve? Now, obviously, we all know that the meaningful goal is to achieve a cure for our patients. But the committee realized that if they set the standards too high, they wouldn't be viewed as credible. Nobody could achieve such high goals. And so they set very modest goals. Most of them are approximately a 25% improvement in numbers that aren't so great to begin with. And for pancreatic cancer, for example, a 4 or 3 month survival advantage. For lung cancer, a 2.5 to 3.25 month survival advantage. For breast cancer, 4.5 months, and for colon cancer, 3 months. 30 out of 71. That's an indication of how poorly we have done, because only 30 of the 71 therapies that were approved by the FDA between 2002 and 2014 would have met the spirit of the modest goals of the ASCO committee. Now, are we doing better? 3.9 and 1.8. That's the median gains in progression-free survival and overall survival of drugs approved by the FDA in 2013. You can see those numbers in red there. For the 2002 to 2014 period, that was 2.5 and 2.1. So we're not really making enormous strides in the recent past. We have seen a drop in the number of patients enrolled in the clinical trials, and now on average 346 patients rather than 582 are being enrolled. So maybe there is some progress and we can be hopeful. So yes, our therapies are not as effective as we had hoped, but because they are so expensive, they're actually stifling progress by encouraging enormous expenditures of time, money, and resources on marginal indications or efforts that really do not advance our therapies. Essentially, once a company has invested an enormous amount of money on the original development, expanding those indications is really a reasonable, if not an important financial decision. So let us look at examples where attempts to capture market share and expand indications have driven our efforts. And let us ask if in doing so, we really are making the progress that we need to make. Let me say here that the examples that I'll show are just that, examples. I could have shown 100 others, and I'm not picking on any particular company or any particular drug. Just try to pick some that might be of interest to you. So in renal cell carcinoma, for example, 26.4. That was the overall survival in months achieved when sunitinib was first tested in a trial published in 2005 that led to its approval by the FDA. 29.3 was the overall survival in months achieved with sunitinib in a 2000 trial published in the New England Journal of Medicine that really was all about putting pazopanib ahead of sunitinib. It wasn't about advancing cancer care. The confidence intervals of the results in this trial and those in 2005 overlap despite the approval of 7 new FDA drugs in that interval of time. So the patients in 2013 are getting the benefit of 6 additional drugs, and still we can't make sufficient progress in their survival. So then renal cell carcinoma, unfortunately, we have to ask, how far have we come? Are we making substantive progress? Or are we searching for marginal differences while staking out market share? And remember, these are values in clinical trials, which, as you all know, are always better than those in the real world. 20, that was the median survival in months for renal cell carcinoma in the community in patients in 2004, before the era of targeted therapies for renal cell carcinoma began. 24, that's the overall survival last year in 2013. So 10 years after the era of targeted therapy began in renal cell cancer, we've gained 4 months. 4, that's the number of months gained during those 10 years, from 20 to 24. Remember that 29.3 months is what was achieved in a clinical trial. So that means that 5 to 6, that's the deficit in months compared to clinical trial results when one looks at real-world accomplishments. It underscores the fact that the marginal gains of most clinical trials are not as meaningful in the real world, where the gains, unfortunately, are always more marginal. How about colorectal cancer? In 2004, bevacizumab garnered its first approval in colorectal cancer. It's the last entry in this table. The PFS gain was 4.4, and the overall survival gain was 4.7. Numbers that we think today are probably somewhat larger than one would really obtain. But that began a decade of bevacizumab trials in metastatic colorectal cancer. So along the way, we stumbled upon a value, 9.7. That was the number of months a retrospective 2008 study said would be gained by continuing bevacizumab in colorectal cancer. This was basically bevacizumab forever. Once you develop metastatic colorectal cancer, you began and indefinitely continued bevacizumab. But this was a retrospective trial, and most people were somewhat skeptical of this value. So that led to 1.4, which is the number of months a prospective trial showed would be gained by this bevacizumab forever strategy. A survival difference of 1.9 months that really was not statistically significant, but that nevertheless led the FDA to approve the use of bevacizumab in first, second, and basically indefinitely in patients with colorectal cancer. 1 and 2.4, that's the number of months that were gained in survival by using bevacizumab once, which was the control arm in this study, or continuously, which was the experimental arm, in colorectal cancer in 2013, when compared to the 21-month survival which the French in a Guercourt study had achieved 9 years earlier. So really, this is the gain that we have made with bevacizumab between 2004 and 2013. So that as with renal cell carcinoma in colorectal cancer, unfortunately, we must ask ourselves, how far have we come? Are we making substantive progress? Or are we searching for marginal differences while staking out market share? Now, in metastatic colorectal cancer, we can now give bevacizumab forever with the best modest gains in survival. But what about moving it up to the adjuvant or the neoadjuvant setting? We want to now bevacizumab not just when you have metastatic disease, but from the time of the original diagnosis. This would certainly be a financially important decision. So that leads to 4,054 and 3,451. That was the number of patients enrolled and randomized in a trial evaluating adjuvant bevacizumab in colorectal cancer, an incredibly large trial, 27%. That was how much more likely it was for a patient giving bevacizumab as adjuvant therapy to die of cancer. 3.2 and 4.6, that's how much more rapidly in months a patient who received bevacizumab died after a recurrence. So giving FOLFOX alone in the adjuvant setting, after a recurrence, your survival was 27 months. It was 23.8 and 22.4 months had you received it in the adjuvant setting. 0. That was the number of patients with colorectal cancer the authors thought should be giving adjuvant bevacizumab if they had colorectal cancer. This is a quote from the paper. On the basis of these and other data, we do not recommend the use of bevacizumab in the adjuvant treatment of patients with curative resective stage 3 colon cancer. So this is a clear example of harm, but are we possibly harming others by trying to push the marginal indications? There's three numbers, 1.2, 1.5, and 2. That's the months of overall survival benefit of 3 EMA, and this being the European Medicines Agency, approved therapies. Cetuximab in lung cancer, that therapy that I was so enamored of when I heard it in ASCO, actually has never been approved in the United States, but the EMA approved it. They also have approved the 1.5-month survival advantage that giving bevacizumab to breast cancer patients confers. In the United States, after an accelerated approval, this approval was subsequently rescinded. And they've also approved paclitaxel and carboplatin in combination with bevacizumab in non-small cell lung cancer. That value was 2 months. But what do we know about these marginal outcomes? We usually rationalize them with 2 words, and that is precision medicine or personalized medicine, something which at this point remains still a hope, a fantasy, and has not been documented to be real of value in patients with metastatic cancer. When we look at this, we think of 2 months, and maybe we can think of it as individual patients, as shown here by the color, and we think that maybe all of the patients are gaining 2 months in overall survival. Actually, we often say to our patients that that was the data, and then we throw in that, but of course, some patients did much better than that. And of course, our patients walk away thinking that they will be the ones that do much better than that. We want to believe that some patients that would have done poorly without bevacizumab do really well with bevacizumab and move from being at the back of the row to being at the front of the row. The problem is when this happens, these patients here at the bottom that should have been moving forward have nowhere to move but backwards. And so consequently, when we're talking about marginal outcomes, we have to recognize that with a median overall survival gain of 2.1 months, we saw between 2002 and 2014 in FDA-approved drugs, many of our therapies are substantially helping only a fraction of patients. They likely have no significant impact on most, and they're clearly harming some patients. We cannot think that everybody is moving forward 2 months or 1.2 months. Some are moving forward at the expense of some that are moving forward, backwards. And the more marginal the therapy results, the more likely we are that we're harming some patients. Now, the median gains in progression-free survival and overall survival of drugs approved by the FDA for solid tumors in 2013 and 2014 is again shown here. And in red arrows are the results in therapies that were in effect targeted, that were personalized. And the results, the median PFS and overall survival gains for these therapies appear to be somewhat better, 4.7 and 4.2 months compared to the group as a whole. But we must recognize that these are yet to be cures and that we still have a long way to go, that even personalizing medicine does not mean curing cancer. Now, May 10th, 2001, that was the date imatinib was approved by the FDA and basically launched the era of targeted therapies in cancer. 22,000. That was the number of patients with a diagnosis of CML, chronic myelocytic leukemia, in the United States in 2001 when imatinib was approved. Imatinib has turned out to be a wonderful and a wonderfully effective drug. So that now, 88,000, that's the number of patients with a diagnosis of CML, or the prevalence of this disease in the United States in 2013, because so many that should have died are still alive. And you can see here the trajectory. By 2050, it's anticipated that 180,000 patients will be living with CML. 1968, that was the cost of one imatinib 100 milligram tablet in 2001 when there were 22,000 patients. 68.75, that's the cost of a 100 milligram imatinib tablet in 2013. That's a 350% increase in price since 2001, during which time the number of CML patients has increased 400%. Clearly, cancer care and cancer drug costs are not like other businesses. You can see here the high definition price of TVs and how that high price has dropped over the years as more and more of these have been bought. You can see here what's happened to the cost of DNA sequencing per base. It has dropped dramatically. That's why today we can sequence somebody's genome for $1,000 or less. And you can see here what happened to the price of computers. And yet, the cost of imatinib went up $350,000. Now, Novartis, the maker of imatinib, have we identified the villain? Actually not. Novartis is a publicly traded company, and Novartis is responsible for being profitable for its investors. And that's what it's doing. It's publicly traded, and that's its mission. Now, I don't want to leave you, though, with the idea that the only thing that is going up is the price of cancer drug costs. And in anticipation of the next speaker, Major League Baseball salaries are also rapidly escalating. So yes, our therapies are not as effective as we had hoped, but because they are so expensive, they're not only driving our thrust for marginal indications, they're also, in my opinion, stifling innovation and creativity by promoting a Me Too mentality. So $102,667. Until recently, that was the median cost of drugs approved by the FDA since 2012 for the treatment of solid tumors. That was how much it cost to treat for a year with these drugs. At the top was a drug called crizotinib, the last drug approved until just recently. And that was a drug approved in non-small cell lung cancer. It was approved for the treatment of patients with non-small cell lung cancer that have a mutation in a gene called ALK. It accounts for approximately 3% of non-small cell lung cancers, and that, of course, is an even smaller fraction of the patients who have cancer. More than 6, that's the number of ALK inhibitors in development. 194,148 and 12.6%. That was the price for 1 year of ceritinib, a drug approved in April of this year by the FDA for the treatment of ALK-positive non-small cell lung cancer. So the price, even in under a year, has risen, and the premium has been 12.6%. 74. That's the percent of oncology agents in the pipeline of the 9 major pharmaceutical companies that have overlapping mechanisms of action. An incredible Me Too mentality that is being driven by the fact that it's well known that if drugs are successful and if they are approved, you can get an enormous amount of money, an enormous return on your investment. But what this is doing is actually stifling innovation. And it's not how we would practice or how we would conduct cancer research in this country were we in charge. We wouldn't have 74% of drugs in pharmaceutical pipelines to be redundant. So there should be no doubt that expensive therapies are stifling innovation and creativity by promoting a Me Too mentality. So the 1970s and the 1990s, those are actually 2 important decades. For baseball, it was the decade free agency began, and that's when salaries began to escalate dramatically. The 1990s is the decade pharmaceutical companies began to increasingly participate in drug development, and then rapidly came to dominate cancer drug development. We have gained much. There's much that has come good from having pharmaceutical companies participate as they do in this enterprise. But we gave up much, much more. So we must acknowledge that pharmaceutical companies now dominate cancer drug development. Much good has come out of this, but it has also changed the drug development paradigm to one most of us would not think optimal. As I said, this is not how we would conduct cancer research were we in charge of that enterprise. However, if we continue with the paradigm of the past decade, one dominated by a Me Too mentality, when the goals of marginal gains and greater market share will continue to sow the seeds of mediocrity, and we will not achieve for our patients the real gains we so desperately need. We really need to bend the efficacy curve, and we need to do it now. I'd like to acknowledge two individuals, Andrew Lowe, a premier economist at MIT, and Sham Malankati, an excellent fellow in our institution, both of whom helped me write what is now online, this paper. And it actually goes into great detail as to the economic incentives for what we're experiencing. And then I'd also like to acknowledge all the people with whom I have worked over the years on this topic. Christine Grady at the top of the list. She began with me on this in 2008, and a list there of the number of collaborators that I've had over the years on these topics. And I'd like to thank you and the organization for the honor of giving this lecture today. I very much enjoyed being here, and I have great respect for all that you do. I often say that the last thing I want to be is a head and neck oncologist, and that's because I know what a difficult road that is, what difficult patients you have, and I really sincerely have the greatest respect for all of you, because you do an enormous amount for patients that do and need an enormous amount of care. And so thank you again for this invitation, and I wish you the best.